Okay, so we are live. Now, if you're online, please introduce yourself in the chat box. Otherwise, we will start the course in 2 minutes. Okay. Then let's start with the first clinical vignette that might make the difference between the upper percentiles at 2ck. We have a 65-year-old patient that comes to the ED due to difficult breathing and waking up during the night. His medical history is notable for hypertension, for diabetes, and prior myocardial infarction. The vitals show 70 beats per minute and 180/110 pressure and a temperature of 37 degrees Celsius. His SATs are somewhere around 88%. On chest auscultation, the heart sounds are normal. There are bilateral crackles in the lung fields. The ED doctor remarks bilateral abdominal broods. What is the most likely diagnosis in this patient? Pulmonary edema due to heart failure, pulmonary edema caused by papillary mass rupture, pulmonary edema caused by renal artery stenosis, or ARDS. Let me know your answer in the chat box. The answer is C. This is what it's called a flash pulmonary edema. The flash pulmonary edema occurs in 2 cases of renal artery stenosis. Either the patient has bilateral renal artery stenosis or unilateral renal artery stenosis with one functional kidney. Now, what is the most appropriate long-term treatment for this patient? Do we give him home oxygen therapy? Do we give him ACE inhibitors? Do we give him loop diuretics? Or do we give him renal artery stenting? We stent actually his renal arteries. In discussing the right answers and the wrong ones, ACE inhibitors will decrease the perfusion, which is already low, and might actually lead to an acute kidney injury in the case of bilateral renal artery stenosis. Loop diuretics also can decrease the perfusion due to hypovolemia. The home oxygen therapy is used for COPD patients. And lastly, the renal artery stenting procedure is indicated in these cases. However, ACE inhibitors can be used due to their nephroprotective role in renal artery stenosis, even bilateral, as long as the creatinine is monitored and no elevation in creatinine is registered. The answer here is D. As we talked about before, the flash pulmonary stenosis or one functioning kidney with unilateral RAS. Let's talk about how this usually occurs and why it usually occurs during the night. Okay, so during the night we have what is called nocturnal hypertension. Let's make it more visible. Great. We have the patient with renal artery stenosis, which has poor perfusion of the kidneys. Now, alongside that poor perfusion, this nocturnal hypertension leads to more severe perfusion, low perfusion of the kidney. Great. Okay. Now, this aggravation perfect will lead to a greater activation of the renal angiotensin aldosterone system, and in turn, due to water retention through aldosterone, we will get volume overload. Okay. Now, this volume overload will lead to what actually causes the flash pulmonary edema. Namely, it will lead to severe hypertension during the night. And this severe hypertension, in turn, will cause flash pulmonary edema, and as we discussed previously, during the night, due to the Okay, let's go to the next set of questions. We have a 35-year-old woman who visits her primary care physician due to inability to sleep. Every time she puts herself into bed, there is an intense urge to move. Once she paced around the house a little bit, she's able to fall asleep. Her medical history comprises 2 pregnancies with vaginal deliveries, diabetes mellitus type 1, and multiple sclerosis. She is currently on natalizumab and insulin. What are the risk factors for her condition? Prior pregnancies, multiple sclerosis, natalizumab, or iron deficiency anemia. You can write your answer in the comments if you rewatch this live stream, or you can write it now in the chat box. Okay, the answer is B. There's a difference between risk factors and etiology in regards to restless leg syndrome. So, in this case, the patient had multiple sclerosis. The patient did not have Parkinson's disease. There was no current pregnancy. Restless leg syndrome appears when the patient is pregnant. Also, RLS is seen with iron deficiency anemia. In our case, the patient did not have any signs of iron deficiency anemia aside from RLS, meaning she should have menorrhagia, she should have pallor, fatigue. Okay. This was a short one. Now, let me know if you have any questions. Let's go to two clinical vignettes that underlie a subtle difference frequently tested at step 2CK. A 56-year-old patient is diagnosed with HIV. His CD4 count is around 100. His prophylaxis treatment includes sulfadiazine and pyrimethamine, trimethoprim sulfamethoxazole, azithromycin, or itraconazole. Let me know your answer in the comments. A 36-year-old woman presents with nausea and vomiting to the ED. On the CT scan of the head are numerous calcified masses. Upon further questioning, she states she used IV drugs up until the last 2 years. The treatment for this patient is sulfadiazine with pyrimethamine, trimethoprim sulfamethoxazole, azithromycin, or itraconazole. Again, let me know your answers in the comments. Okay, the first question asks about prophylaxis. The prophylaxis for toxoplasmosis is done with trimethoprim sulfamethoxazole. In comparison, the treatment when we have diagnostic criteria such as calcified masses with a history of IV drug use is done with sulfadiazine and pyrimethamine. Indeed, Toxoplasma gondii also has the same prophylactic method as pneumocystis jirovecii pneumonia. So when we have a HIV patient with a CD4 count less than 200, we put him on trimethoprim sulfamethoxazole for both pneumocystis carinii and Toxoplasma gondii. Another thing deemed to be said is that azithromycin is used as a prophylactic method against Mycobacterium avium complex in HIV patients when the CD4 count is below 50. Okay, are there any questions? Thank you for the participation. If you liked this type of video, give a like and share it with friends. I wish you a good day.